So welcome to what I always think is the best part of any nursing course, and that's the part where we start to link the theory to the practice. And what we're going to be looking at in this short video is the AF patient annual review. Now, it might be that, if you're new to general practice, that you're not asked to do the annual reviews just yet, but you might, it may be that you're doing follow-up reviews 3 monthly or 6 monthly. But the thing is, everything that we cover in this video will more than cover what you need to carry out at a follow-up review. Before we get into the structure and then the content of the AF patient review, I just wanted to have a very quick word about the difference between the annual QOF review and the national guideline annual review. And the reason why I'm saying national guideline is that we are going to be doing other diseases within this series of modules, and different disease areas can be governed by different organisations. For the purpose of atrial fibrillation, we do tend to follow the NICE guidance. But when we get into things like asthma and COPD, we might be following a different set of guidelines. But anyway, that aside, often in general practice, you'll see something different in the annual QOF review versus the guideline review. So as you can see here, if we look at the latest QOF for AF, there is always points for the GP keeping a register. But then if we go down and have a look, percentage of patients in whom stroke risk has been assessed using the CHAD-VAS score, which we've covered within the course of this module. And it says excluding those that had a previous score of 2 or more. So that's what we need to do. And then, of course, if you identify somebody who is at an increased risk of stroke, we have to do something about it. So that really is what the QOF asks for. But let me now show you what NICE recommend within they have a section called clinical knowledge summaries that's really useful. And if you click on this little link here, that'll take you to it. But I have summarized it here for you. So let me just show you what is in the NICE guidance with regards to follow-up. They do take it a little bit of a step further. They ask us to check for symptoms and assess heart rates, etc. They still do what the QOF asks for, but they do, encourage us to manage risk, to be sure that our patient hasn't developed any complications, a medication review, and then patient education and advice. For the purpose of this module, we are going to be covering this. Again, the reason that we're covering this is that when we do that, you will more than meet everything that you need to meet for the QOF. Now, the thing about the annual review, it's kind of not just about collecting data and putting it in a computer. It's about helping us to deliver the aim of treatment of any of the diseases that we look after. And so I just want to very quickly refresh your memory of the aim of treatment for atrial fibrillation, because when we know what the aim is, we then know the questions that we need to be asking and the data that we need to collect. So I know that you've seen this before in an earlier module, but first thing for AF, we want to prevent, but we also want to relieve any symptoms that the patient might be having. We also want to make sure that the heart rate and rhythm is normal. We don't want to leave them with AF or a fast pulse. We want to prevent them having an embolism, and then we want to reduce the future risk of stroke. I just want to mention something else about this, because this is one of the big aims of AF therapy. The risk of stroke, it is 5 times higher for patients that have got AF. And 20 to 30% of all strokes are actually linked to atrial fibrillation. And the Stroke Association, they estimate that if we treated this condition properly, about 7,000 strokes were prevented and over 2,000 lives saved every year, and that is just in England. This is not across the UK. So the big aim and the big focus that we're going to be going through now for the rest of this video is we're going to be looking at how do we reduce the future risk of stroke in our patient. Okay, so what do the guidelines say about the AF patient review? Well, they actually say that we should review these people at least annually, but this is only once symptoms are controlled and that any drug treatments that we're using or dosages are established. Now, it may be that these patients need reviewing more often. They don't kind of stipulate that we have to do it every 3 months. They just say using clinical judgment. Now, the thing about this is if you're being tasked with doing these follow-up reviews, you may have a patient who was diagnosed 2 years ago or a year ago even. And we're in this first year of trying to sort out symptoms and get treatment regimes established. So, these follow-up reviews, I think sometimes in general practice, there's a huge importance and emphasis made on the annual review. And that, I'm not discrediting that. That's absolutely how it should be. But I don't think that we should undermine the importance of the follow-up reviews as well. And I don't know how it's going to work in your place of work. It's different everywhere across general practice. But what we've tended to see over the years of the work that we've done in general practice is that when someone is new to a disease, they tend to do the follow-up reviews. And then once they kind of start to understand the purpose of that review and they start to get a little bit more confident, they then are expected to take over the annual review. I think one of the reasons for this is that if you can imagine, if you were in general practice and you were being tasked with doing the AF annual review, it could very well be that you're the only person in that surgery who sees that patient within a 12-month period. So, I had no idea how it's going to work for you, but what we are now going to do is we're going to go through the annual review. But just remember, everything that I cover now, you will be able to use in a 3-month or a follow-up review. So I hope that makes sense. So let's meet our patient for the purpose of this review. So here she is, and she is the lovely Anne, who is 72 years old. Now then, you may remember meeting Anne 2 years ago when she attended for her annual angina and hypertension reviews. And at that review, you did notice that she had a fast and irregular pulse, and you referred her quite rightly onto the nurse clinician who ordered a 12-lead ECG, and ultimately Anne was diagnosed with paroxysmal atrial fibrillation. Now, at diagnosis, a CHA2DS2-VASc score was carried out, and that came up at 3. And then she had a bleeding risk score, which came up as being 0. And because of this, she was therefore prescribed a DOAC in line with NICE guidance. Now then, Anne is here today for her first annual AF review after diagnosis. So that's what we're tasked with. We're going to be doing Anne's very first annual review. So let's get on with this annual review then. So let me show you what we're going to be covering in this video. We're going to individually go through each of these elements, and these are all based upon the recommendations that are made within NICE. So we're going to do each one in detail, one by one. So let's start with checking for symptoms and assessing heart rate. And let's have a look at what NICE tells us. Well, what NICE is saying is that at rest, we would expect for Anne to have a pulse that is somewhere between 60 to 80 beats per minute. We also don't want for it to be irregular neither, so we need to check a pulse. If at this point you find anything that is untoward, if the pulse is too fast or there is any arrhythmia in there, this person will need referring on to the clinician within the surgery who's got the ability to intensify or change any current prescribed medications. And this depends on where you work. It might be you've got a prescribing nurse, it might be a nurse clinician, and it might be the GP. It just depends on where you work, does this. So let me take you through what we discovered with Anne. Well, we discovered that her pulse rate was 76 and it was regular. And so we're really quite happy with that. There is nothing to report. It's falling within recommended parameters. And she also tells you that since her diagnosis and since she started on a treatment, she hasn't actually felt any of those fluttering sensations that she used to feel in her chest. And so therefore, with regards to the first aspect of the annual review, I think that there isn't anything to report. It will, you'll be more than justified to enter this data into the computer and not put it on your to-do list. If you remember in the other video, we had that little to-do list that we kept popping things on when something came up that we needed to not forget to pass on. So I think we're quite happy with that. So moving on, NICE guidance recommends that we reassess stroke risk. And if we have a look at where Anne's up to today, nothing has actually changed since her original assessment, and her score remains at 3. So there is absolutely nothing to report here. And this is one of the areas that is slightly different between the QOF and the NICE annual review recommendations. If you can remember that the QOF excludes having to reassess CHA2DS2-VAS in any patient that has a score of 2 or more. So for the purpose of Anne, we didn't really need to reassess it. But let's be honest, you're not going to be always getting Anne's into the surgery for the review, and it's just good for you to know that in some instances you will need to reassess it. So this next part is something that is included in NICE but is not a requirement of the QOF, and this is the reassessment of risk of bleeding using the Orbit tool. So let me just get this up for you there. Now there has been one change since Anne's original assessment, and that change has been that her EGFR has fallen to less than 60. So this is a change from the original, and this has increased her bleeding risk score, and it's gone up from 0 to 1. But the thing is, she is still in the low risk group. So again, there isn't anything to report with regards to the risk of bleeding. One thing that you might want to be sure of is that somebody within the practice is aware of the EGFR falling to less than 60. I would expect for that to be the case, because I would expect for when the bloods to come back into the surgery that they normally go through a clinician, and a clinician would pick up on that. So it might just be an idea to have a quick route around the records to be sure that someone's passed a comment about the reduction in the GFR. In the next video, we're going to be looking at the CKD, and that will become more apparent as to why you just need to keep your eye open for that. Something else that the NICE guidance asks us to double check on that is not included in the QOF, and that is to reassess cardiovascular risk and then identify any modifiable risk factors. But we did this when we first met Anne 2 years ago. Now what NICE do recommend is that if applicable, we should generate another Q risk score. And then we should have a look at all the individual findings. We should look for any changes in blood pressure and lipid levels, anything that would increase Anne's future risk. But the thing about all of this, all people with a diagnosis of angina are assumed to be at a high risk for cardiovascular events. And so therefore, with regards to Anne, there is absolutely no need for us to generate a Q risk score. But that might not be the case with all of the patients that you see within an AF clinic. So it's always worth double checking whether or not you do need to reassess Q risk. For Anne, we don't have to do anything about that. Anne stopped smoking 7 years ago, which is wonderful. Obviously, if we had a patient that was still smoking, that would definitely go onto our to-do list, and we would have to look at how we can assist and help this person in smoking cessation. She still admits to having a bit of a sweet tooth, but aside of that, she tells us that her diet is good. And Anne's definition of a good diet is that she cooks all of her own food. She doesn't do fast food. She doesn't do ready-made meals. Anne's BMI is still falling into the overweight category, and that might be something that you want to put onto your to-do list. It might be that Anne has been trying for this last 2 years to lose weight but has not succeeded, and she may need a little bit more support in that. But she does tell you a positive is she has started to do more exercise. One of the things that was stopping Anne from doing exercise was her AF symptoms, and she was afraid that this was a sign that she was going to be having a heart attack. But since her symptoms have come under control, she's now got a little bit more confident, and she tells you that she now walks for at least 30 minutes every day, which is brilliant. It's fantastic, and which does, deserve, we should be telling Anne that this is fabulous. She's making a brilliant move forward here, especially, if you remember back to when we first met her on the angina review, that she was terrified of exercise because of this sense that she was having a heart attack. So that's a real positive in Anne's progression, this. And she also told us that previously she did used to enjoy a glass or two of wine every weekend, but she's now cut that out, and she only really ever has an alcoholic drink on special occasions. And this is another real positive. It is. Again, Anne's doing a good job, but we do need to double check about the units of alcohol that any patients are taking, but especially patients with AF. So I think Anne is making really good strides in the right direction, and for us, we need to tell her that, it's these patients, they need our support. All too often, patients with long-term conditions, they come in and, we're forever saying, oh, you've got to lose weight, you've got to increase your exercise, you've got to do this, that and the other. And it can be really, really overwhelming. I mean, it would be overwhelming for me. And so when you start to see little glimpses of progress, I think we need to just really, really jump on that and praise our patients and, commend them for making these changes, because it's not easy. I'm sure that all of you listening to this at some point have attempted to make a lifestyle change, and maybe you've not been successful. And it gets you down sometimes, I think. So good on Anne. She's made some really positives. Yeah, there's room for improvement, but she's going in the right direction. Now, this is a really, really important part of not just an AF review. It's an important part of all of the long-term condition reviews. Even though she's coming in and she's coming in for her AF assessment, if you think about what AF is associated with, well, we can't just have us sitting there and us not go looking for it. I mean, if you think about something like type 2 diabetes, we know that patients with type 2 diabetes are an increased risk of developing CKD. So imagine us not checking for CKD in an annual diabetic review. It is unheard of, is that? And I think we need to kind of take that mentality into all of the other diseases. I mean, when we get into the respiratory modules as part of this program, and certainly with things like COPD, patients with COPD on average have got something like 2.5, if not more, comorbid conditions. And part of our COPD review is often finding the undiagnosed cardiovascular disease that they've got. So this is a really, really important part. Now then, with regards to AF, there's 3 biggies: stroke, thromboembolism, and then heart failure. So while we're doing our chats to Anne and we're asking her all our bits and pieces, there is absolutely no evidence that Anne has had a stroke. There's also no evidence that she's even had a transient ischemic attack or any thromboembolism since her last review. So on that score, we could probably say, we can leave that in peace, and we could, just note that there's nothing for us to report at this point. However, you do notice that both of Anne's ankles are swollen. Now, this might be something and nothing, this, but it might be a sign that she's got heart failure. And in a way, it's not our job really to say, oh, it's probably because she's on her feet all day. It might be, but it might not. Our job is to notice the irregular. And a person with AF and angina and high blood pressure presenting with swollen ankles, especially in both of her ankles, that we can't ignore that. And you need to investigate further. And when I say investigate, I mean getting a more clear history of the patient. So Anne tells us that this has been coming on now for the last 6 months, and that at the end of a day she has to put her legs up elevated on a stool. And Anne tells you that this helps for the swelling to go down. Now, this is something to go on our to-do list, because heart failure is a complication of atrial fibrillation. Heart failure is massively underdiagnosed as well across the UK. And so this is something that you're definitely going to have to put on your to-do list. Okay, so put that onto your little to-do list, and we'll pick that up at the end of the assessment when we start making our intervention plan. So the next part of all of this is a medication review. Now, we went through the angina and the hypertension review in the previous video, and so I'm going to leave that in peace. Otherwise, I'll just bore you to death. What we're going to focus on now is this new class of drug that we've come across, and these are called the DOACs. Now, remember, it isn't your job to intensify therapy. However, if you're doing a patient review, you do need to have some awareness of the potential side effects, because you may need to report any of these side effects to a clinician who might need to make changes in the patient's treatment regime. So let me tell you what NICE say. The DOACs, a couple of things for you to focus on. One, they should be taken at the same time each day, and it should always be taken with food and water. So that's something that you need to ask. The other thing to remember is that they are short acting. So it is really, really important that your patient takes these medications at the same time each day. And obviously, this is an obvious example, but if your patient is prescribed a twice daily dose, then it must be taken 12 hours apart. So 8 a.m. or 8 p.m. But that's obvious, but I'm just highlighting this because it is important. Now, the main side effects of this particular class of drug is unexpected bleeding or bruising. So, of course, you need to kind of focus on that. And when we talk about unexpected bleeding or bruising, some of the things to keep your ears open for, or to even ask direct, are things like, have they had prolonged nosebleeds? And when we talk about prolonged, we're talking about something that's lasting more than 10 minutes. Or what about prolonged bleeding if they cut themselves? Or if they start to notice blood in their stools? And also another one to just keep your ears open for is spontaneous bruising. If they suddenly notice that they've started getting these bruises and they can't even remember knocking themselves. And last but not least, with regards to this main side effect for bleeding and bruising, is unusual headaches. So just ask those questions, and just, if anything's reported, put a little note down so that you know not to forget to pass that on. Some patients may experience nausea or diarrhea or heartburn. So let's have a look at what Anne tells us. First thing is, when we went into her notes and we looked at that repeat prescribing, that indicated that she was requesting her medication on a monthly basis. Now, if you remember from the angina one, just because a patient requests something, it doesn't mean they're taking it. So one of the ways that we would discuss this in clinical practice on our projects, we would say, oh, I noticed that you are requesting your medications once a month. Can I just double check that you are taking them every single day? Because, the reality is some patients will just they'll get the prescription, but then they don't actually take the medication. Okay, but with regards to Anne then tells us, she says, yeah, she takes them every single day, But one thing that she does tell you is she is not taking them 12 hours apart. But now that she knows that she needs to, she's going to do that from now on. Anne says she's not got any problems with unexpected bleeding or bruising. She can't recall any issues with that. And she also tells you that at the beginning she did have some nausea, but it's now settled. And the thing about that is, because it's settled, it's unlikely that it's going to stop Anne from deciding, oh, I'm not taking these medication anymore. But if you were reviewing a person at the beginning of the therapy and that they were still having these symptoms, then this is one that you would need to put on your to-do list to refer on, because it can be that ultimately the patient will think, oh, do you know what? I can't keep living with this nausea. It's driving me mad, or this diarrhea, and they might decide to stop taking the meds. So it's positive here that yes, she did have some nausea at the beginning, but it's now settled. So we're quite happy with that. And again, I don't think that there's anything to report. What I would be doing is writing in the records when you write up your assessment, is that on a discussion with the patient, she did mention that she wasn't taking her medication as prescribed. She's taking it every day, but she wasn't taking it with an appropriate space between each dose, and that you have advised on that. It might even be that when you go into the clinician or whoever it is within your practice that you're going to be reporting to, it never does any harm to just mention that. Okay, so I hope that has kind of made sense. Remember, as a nursing associate or a nurse new to general practice, it's not your job to start to change therapies, but it is your job to be sure that everything is okay with the medications that patients are taking, and then to report on. Again, I think it's almost a given, isn't it, that whenever we get a patient, we should be talking to them about education and advice. Again, there's no points attached to this in the QOF, but the NICE guidance are big on education and information, which I totally agree with. So when we talk about advice, what is it that we should be mentioning? Well, again, we're going back over vaccinations, maybe mentioning about the AF Association. A lot of these long-term conditions, they have absolutely brilliant websites, not just for patients, for us as health professionals. You can learn so much. Almost all of them have got two sections. They've got a patient version, and then they've got a healthcare professional version. And they're an absolute wealth of really important pieces of research. They're fantastic, they are. And I would, we're talking here about patients, but if you're new to any disease area, I would massively recommend that you go and get onto the patient information websites. The DVLA is always a biggie. And again, our advice is we have to advise them that it's actually their responsibility to inform the DVLA. It's not our responsibility. Again, you've got to cover yourself, put this in. What you don't want to happen is the person doesn't inform the DVLA and you've not recorded in a set of notes that you've all advised them. Something as simple as I've advised patient to contact the DVLA and also their insurer, just to be sure that it's on record. What you need is you just need it on record. This one's a real biggie, this actually, with the insurers. And if your patient's got some evidence that they've called them and the insurer says no, it's absolutely fine, then at least they're covered as well. And again, travel health advice, in the olden days when I started, we never went abroad. We never went on an aeroplane. The furthest we got was Rhyl, I think. But that's not how it is today. Patients are travelling, and they're travelling, people are living longer. And so we're getting older patients travelling with long-term conditions. So again, it's really, really important that if your patient is a regular traveller, that we guide them to the right place for travel health advice. Certainly with things, if you think about it, one of the aims of AF treatment is to prevent an embolism. Well, if you think about the risk of being in a pressurised container at 30 or 40,000 feet, you know, in the sky, going from a cold to a warm area, the risk of embolism is huge. So that is what NICE guidance recommend that we do. Let's see what Anne tells us about this. She never misses her annual flu jab, and she's up to date with a pneumococcal and all COVID vaccinations, so we're happy about that. She tells you she doesn't drive anymore, and nor does she travel outside of the UK. She tells you that she doesn't use a computer as well, and she asks if you might be able to provide her with a booklet about AF. I think this is really important, in this day and age where almost everyone has got access to a computer. There are still some patients who are not computer comfortable, if you like. Sometimes, I mean, they've got grandchildren that can help them, but Anne tells you up front here that, she doesn't use a computer. I think from our perspective, certainly when I started, we didn't have the internet when I started in general practice. It was that long ago, and our waiting rooms, they were full of patient information leaflets, and we all knew where to order them from. But I think as time has passed and the internet has taken over, it's always quite easy to give our patient a list of websites and say, here, go and have a look on here. But we always got to be aware that some of our patients may not. And this is why it's really good for you as a healthcare professional to know what's available in a printed form, but more importantly, how can you get your hands on it? And that's what we're going to have a look at now. I've got a couple of examples for you, and I have uploaded these PDF copies of these booklets so that you've got them there. However, let's just crack on and have a look at what is it that you might be able to get your hands on. All of the long-term conditions, they have all got charities who, work tirelessly, and they're generating funds to perform research. But one of the things where they really, really excel is in the production of patient information leaflets. Now, I've found two examples for you. The first one is a quick guide, and it's absolutely brilliant. But the British Heart Foundation, I'll tell you what, they do some cracking patient education tools. They're amazing, the British Heart Foundation. It is absolutely, if you've got 10 minutes, it's really worth your while to go on that website and just have a little look around at what is available. So that's your quick guide, but the one I wanted to focus on is this one. So this is a full-blown version. Have a look at that, 51 pages. And as you can see, it goes right the way through everything that a person would need to know. There is another thing as well about these guides, is that the British Heart Foundation and all of the other organisations, they also make sure that the wording and the way in which the information is presented is understandable for most patients. So I definitely recommend that you guide our patients. If they're on the internet, there's nothing stopping them going. They can download this, but you can also order these free of charge. So to start to kind of tidy everything up, at the end of our assessment, we've come up with one new, but it's an actual problem, and that is of bilateral ankle edema. Okay, so that's the fancy term for swollen ankles. It's really important as well that it's bilateral. Sometimes patients can get swelling in one leg. And again, you need to notice that, because that might be one of the signs that they're getting a blood clot in that leg. But for the purpose of thinking heart failure, often it'll come in both legs. One of the things that I used to do when I was doing a review, I would always know how far the waiting area was to my room. So I would know that it was 20 yards. And when the patient came in, I would always have a look at the level of the breathlessness as to when they were coming in, or how fast the pulse was. It can be such a good barometer, if you like, as to what's going on. So if you know that your patients only walk, say, 10 yards and they come in and they're very breathless, and you check the pulse and it's very fast, that's not normal, and that might be the first clue to that something's, you know, not quite right. One of the things that I always do when I'm doing a cardiovascular review is always check for ankle edema. And I usually do this when I'm doing the pulse, because if you remember, when you're checking a pulse rate, we have to count for a minute. Now, we all know what happens in real life. People count for 10 seconds and times it by 6. And that's fine, you know, we've all done that, but the proper way of doing it is counting for a minute. And that's the best way for checking for this. So as I'm counting, I'm always checking both of their ankles, making sure everything's okay. But with Anne, we did notice that she got this bilateral ankle edema. Now, if you remember, what we're looking at here is the old-fashioned nursing process. So let's have a look at the potential problems. Well, she might have heart failure. Now, remember, she might not, but that's not our shout, is it, at this moment in time? Our shout is spotting for things that are not right and making sure that Anne gets sat in front of a person that can then do something about it. So what's our target? Well, we want to either exclude or confirm the presence of heart failure, because heart failure and stroke hold hands together. You know, when you've got a patient that's got AF, angina, hypertension and heart failure, the risk of, you know, them having a stroke, it's huge. So we can't ignore this. So what we're going to do then? Well, this is definitely top of our to-do list. We're going to inform the clinician of our findings, and then we're going to follow up as per clinician's instructions, which I suspect will be in line with NICE guidance on the diagnosis of heart failure. And that is almost certainly going to include sorting out a blood test for something that's called the NT-proBNP. And it's almost certain to include a 12-lead ECG. And I don't know how it works in different surgeries, but you might very well be the person who's carrying out these investigations. But the biggie is to also arrange an appointment with the clinician to discuss the results and then the next steps. And that kind of concludes our assessment. It doesn't conclude our job, if you like, because we've now kind of got to make sure that, you know, we don't forget to do these things. And this is where our to-do list comes in. So what I would be suggesting is, in the first instance, it is that you have to report any findings that you have identified as being an actual problem to a clinician. With regards to Anne, we have identified bilateral ankle edema. Now, your to-do list may very well grow following on from that clinician, and it might very well be, all right, wonderful, can I ask you to sort out an NT-proBNP? And they might even ask you to do that there and then, you know, depending on what time of day she turns up. And it might very well be, and can you also sort out a ECG as well? So remember, every time you go to the clinician, there is a strong possibility that your to-do list will grow. The next thing on your to-do list is go and check to see if the surgery has actually got a supply of printed patient information leaflets. They might already have them, and then you can send Anne away with this information. Obviously, if not, it might be that you'll say, well, I'll tell you what, Anne, I'm going to get onto the British Heart Foundation today, and part of my to-do list is to order a supply of leaflets. And you know what, while you're on that Heart Foundation website, there's no harm in you ordering other leaflets as well. You know, it might be that the surgery has not kept itself up to date with leaflets because of the arrival of the internet. And I think that's about it, don't you, on our to-do list? Just to finish off this little video then, that is a summary of everything that we've gone through, and I'm going to make that summary available for you on a PDF. So within the module, just keep your eye open for some extra downloadable materials. Now then, I hope that you found this useful, and then I hope to see you in the next video, which will be the annual chronic kidney disease review. So I'll see you then.